from anatomy onto some burns talks now. So this rather unfortunately coloured, multicolored character is what we're going to study next. We're not going to go into any genitalia anatomy. Don't worry, that isn't going to be something that we need to be bothering too much with. So I'm sure, some of you may or may not have seen this diagram before. So this is a diagram of how we assess burns and the significance of burns. So in terms of burns, I mean, what are we talking about? So we're talking about when the skin is exposed to significant high temperatures, whether that be from direct heat, whether that be from hot water, hot oil, but actually the actual surface of the skin is damaged and is no longer integral as a result of a thermal of a heat injury. And the reason it's so important is because the skin provides one of the sort of most important defences in the body. So it's got lots and lots of functions, and some of the functions are working. So actually being involved in regulating the body's own heat. So making sure that we are losing enough heat if we're too hot, or making sure that we're conserving enough heat when we're too cold. These are all really important aspects of the skin. They also help to provide a really useful barrier for infection. So that's why if you've got cuts, places, people say you've got to make sure it doesn't get infected, because once you've broken that layer, you lose the integrity and you risk picking up infections. And there are lots of other functions of skin, which if there's a dermatologist listening to me talk right now that have their head in their hands, I'm not giving you a really comprehensive list, but these are the main things we need to think about. But when we've got a degree of body that's been burnt, we then need to have a little think about how we're going to calculate how much has been burnt. And that's where this diagram comes in. So this is what we call the rule of nines. So everything here, apart from the 1% of the genitalia, is a multiple of 9, and things change ever so slightly for children, but we won't stress too much about that. And obviously in very obese adults there will be a change as well, because there will be an increased amount of skin in the trunk. But by and large, a good, reasonable way forward of approaching this is the rule of nines. So you assess what area of the body has been burnt, and then you apply it to this diagram, and then you can work out from that what percentage, and that's a really useful way of helping to sort of prognosticate or work out how poorly your casualty is, and being able to sort of escalate care, and this is mentioned in the syllabus. So head and neck, if you had a significant area of the head and neck cover, that's 9%. Each upper limb is 9%. Each lower limb is double that, so that's 18%. And then you've got your trunk, so your front and your back combined is 36%. So obviously if it was all the front or all the back, you could then take 18% for each. With the genitalia, they just put that in, I think, just for the to make sure it rounded up nicely to 100%. So this is a diagram to be aware of, and to have to have it in the back of your mind. And then if we see someone who's had a burns injury, it's important that we know what we're going to be doing for them. So burns, and we talk about the skin, we mustn't forget that we're talking about any form of tissue that's been potentially exposed to that heat. And if you imagine that the airway, so your mouth, your lips and your tongue, all the way down into the interior lining of your lungs, is still a continuation of the air that's being exposed to the environment. So these, the inside of the mouth and your airway, are all areas that can be injured and undergo damage through a burn. And often this is one of the more critical areas that can cause very immediate and severe harm from a burn, because as we talked about before, if you've got all the lining of this tissue, if that becomes burnt, the body's reaction is to send lots of agents via the blood to try and fight it off and to try and make it better. So you get lots of swelling, and then that potentially causes an obstructed airway. So what do? We sit them up, consider giving them oxygen. We reassess them, and if there's any wheeze in the chest, we consider giving them salbutamol. Fluid loss is really important. So the skin provides a really important barrier to the body conserving fluid. So fluid loss is a potential big risk, and that's one of the reasons why we need to act quickly. It's also worth mentioning that it's going to be very, very painful, but due to the sort of severe injury, blood is being diverted away from the food tract, and so you may get the oral tablets aren't absorbed as well, and we may have to resort to intramuscular or intranasal if there aren't any significant burns to our airway passage. So what are we going to do for them? Well, again, it's all pretty simple stuff. So no particular heroics. Any area that's obviously burnt, we're going to try and cool the body. So we're going to try and cool that direct area of skin with cool water. The guidelines seem to suggest this 20-minute mark is optimal. Now, I appreciate that if there's a significant burn on a hillside, which could happen, that there have been aircraft crashes in the not too distant history of Numera, and that certainly would be a type of environment where burns would be a major component. You're not really going to have a running tap for 20 minutes available to you. So these are all guideline driven statements, but the practicalities is that you can only do what you can do, and if a couple of bottles of water is what you've got, then a couple of bottles of water is what you've got. If clothes, especially sort of polyester or plasticky based clothes, have actually become stuck to the skin, they've burnt onto the skin, you don't try and remove that. You can continue to cool it, pour water over it, but leave it in place, because by trying to remove that, you may continue to worsen the amount of skin that's being lost and damaged, and you're potentially removing with it a layer of skin that's at least forming some form of a protective barrier in the short term. Clearly, in the long term, it will have to be removed, but that will be a situation in a hospital situation where that should happen. So if clothing is stuck to it, then remove it. If clothing is loose, it would not be unreasonable to remove that. But then this brings us back to this concept of the skin providing this really important thermal barrier for the body. So if you start stripping them off and they've got large areas of skin that is no longer working, then they're going to get cold very, very, very quickly. And so you have to make sure that with every decision to take off a layer or item of clothing is being matched with some way of protecting them from the elements and protecting them from getting cold. So basically, immediate action is pouring as much and as continual cool water on the affected areas for as long as possible. Administer oxygen and have a mind on an airway management, and try and keep them protected from the elements, stop them from going cold, and evacuate. And I'm not sure there's a great deal more that needs to be said about that necessarily. Anything you want to add anything to that?
You mentioned pain relief. Could we use Entonox to start with, if in intermediate, and then move on to the harder drugs, or?
Yeah, that's a good question. So I don't. As long as there's no significant lung injury, so no significant inhalation injury, if it's just a skin injury, I can't see any reason why Entonox would be contraindicated. So one of the main things about Entonox is that if there's any potential pneumothorax, if air is in the wrong place in the chest, then Entonox is bad news. Now, to my knowledge, I don't think you can get a pneumothorax from an inhalation injury, but it probably, common sense might rule that, if you're out in the middle of the sticks, let's not give them a rapidly inhaled drug if you've got an organ that's injured. So if there's an inhalation injury and we think there's maybe soot, so it's probably worth So in terms of inhalation injury, one of the main ways that we can talk about this, if there's soot or any singe marks in around the nose or the mouth. So if there's any suggestion that there's been a significant inhalation injury, I'd probably avoid it. But other than that, if it was, say, an isolated, leg burn or torso burn, yeah, I think it would be reasonable. I'll have to double check, and I'm happy to stand corrected, but I don't see any obvious contraindication.
Thanks.
Just one thing on the cooling. Possibly in the mountains, you might have access to a mountain stream. Would that be the lesser of two evils? Potential risk of infection and not sterile water, but rapid cooling. Would that be the lesser of two evils?
Yeah, I think so. Because I think that your description of a mountain stream is pertinent, isn't it? Because
rather than a muddy puddle, I'm thinking a mountain stream.
Yeah. So yes, I think that would absolutely be an appropriate way forward, because at the end of the day, what you're doing is you're taking potentially viable skin that can still have that still has a blood supply and still works as a functioning organ, and you're trying to stop it from turning into a destroyed skin, which allows infection to happen. And at the end of the day, I guess these casualties are going to end up in hospital, and they're going to be administered lots of antibiotics, regardless. So there's going to be some, at the end of the day, some antibacterial cover given by the medical teams. So yeah, I think that the mountain stream scenario, absolutely, I'd use that liberally.
Okay, cheers.
So I've got another one on airways and fentanyl. Would that be the same thing with fentanyl if they've got some kind of burns? Because we don't, we're running low on nasal diamorph and intramuscular morphine, aren't we? So
yeah, so I would probably apply the same principles. So I think that the fentanyl lozenges would be a really appropriate use for burn pain management. I think that if there's a lot of suggestion of an inhalation injury, the question would be would you be absorbing the fentanyl that effectively anyway? But if there's significant concern over an inhalation injury, I'd probably be trying to find alternative ways. So intramuscular, ideally. I'm not saying that it's a contraindication. I'm just saying that I think there may be alternative first choices.
Okay, thanks.
Anything else on that? Okay, fine. We don't really cover burns that frequently. It's been a long time since I've even thought or read much about it. So it'd be interesting to see what the thought processes would be behind some of the other medics in the teams, if you guys, I don't know if anyone's here, but if you guys end up going back to your teams, by all means have the same discussion with them. But those have been my sort of basic principles. Fine, so we'll go from one extreme to another, again keeping it nice and fluid and dynamic. I've provisionally put us down to sort of working towards 9 o'clock-ish. If I find a natural break, I'll take it. But if people are starting to peel off like flies, then just let me know and we can stop it earlier. Otherwise, I just thought I'd make the most of getting people online and go till about 9 o'clock-ish. So hypothermia. So this is a really important one for your written paper. And I suspect that there will be several questions on hypothermia. So having a good awareness of this is particularly important. Certainly in terms of active treatment on the hillside, it's something that some of the Scottish teams would have to be very familiar with. I suspect that some of the teams like Llanberis and Ogwen would have potential some exposure to. Some of the other teams maybe not. But certainly for the written exam, this is going to be really important. So this is all based around a document written by MREW around about hypothermia. Now there's a few documents that I keep mentioning, and I'm happy to send them round if anyone wants them. I know that my team, if they haven't got them already, they'll have them shortly. So I mentioned the overall MREW syllabus as number one, and secondly, I've mentioned the MREW hypothermia guideline. So these are nice things to have as PDFs on your phone, ready to be looked at. So we base it around this sort of Swiss staging of hypothermia, where we categorize how cold someone is. And we try and work out what grade they're in to help us determine how poorly they are, and their risk of death or their risk of survival. Now there's temperatures here. Now we don't carry thermometers. Well, most teams don't carry thermometers, but they're there more for you as a guide to understand. As a guide. Sorry if you can hear my wife singing while she cooked her dinner. I do apologise. I might just shut the door. Oh. She's clearly very happy that she's got the evening to herself. We've got so stage one. So clearly conscious and shivering. So if we call a normal temperature around about 36 degrees, so we're just under that. Then we've got, and that's a mild hypothermia, and I'm pretty sure that we've all encountered that ourselves. I'd be very surprised if any of you hadn't been at stage one at some point in your life. Next, we've got stage two. This is where our conscious level is starting to become impaired, so we're becoming quite drowsy, and then we start to lose the function of shivering, and this is starting to become a really worrying sign. So shivering, the actual process of shivering is where you've got really intense muscular contraction. So your muscles start to contract and release, and by doing that, it generates lots of heat, and that's what keeps you warm. Now, if you're cold and you're shivering, but then the shivering stops, it usually means one of two things. So one is that you've warmed yourself up, or two is that the body's starting to lose the ability to shiver, and that can often be because it's starting to use up the fuel supplies, so the energy and the sugar in the body to be able to continue the muscles contracting, and therefore the body's starting to lose its protective reflex. So this is when things start to get a little bit hairy, because you're just starting to teeter on that slope of someone becoming really quite sick. Because as soon as the body stops being able to protect itself, you then start the rapid cycle of continued heat loss, unless you can get some external factors in to help warm the body up. Stage 3, they're now unconscious, but you can still feel the pulse and they're still breathing. So obviously this is really serious stuff. Stage 4 is where essentially the body appears like it might be dead, but actually there's either a very, very faint or very, very slow pulse, the occasional breath. So we're not talking about a normal breathing rate, we're not talking about a normal heart rate. We may be talking about 10, 15 beats per minute. We might be talking about a couple of breaths per minute. So the body's in a complete shutdown state, and we're essentially cold to the state that we're beginning the process of dying, and that will happen in due course. And then stage 5 is where the body has died, and it's no longer irreversible. And then there's this really weird temperature of 13 degrees, which is where that cutoff is, and the only reason that cutoff is there is because that's the lowest temperature that the human body has been resuscitated from. It's not to say that the body couldn't be resuscitated from below 13 degrees, but that's the lowest recorded. And I think it was, I forget the exact story, and someone can correct me, but I think it was a Norwegian anaesthetist who was skiing and went through a crevasse and got immediately submerged immersed, not submerged, into very, very icy cold water, got immediately chilled down to a very, very low temperature, and then was transported to the hospital where she was resuscitated from, I think it was about 13.4 degrees in her own hospital, which must have been quite a strange thing to happen. So anyway, there you go. That's just a little bit of knowledge tidbit to go with that. So those are your rough 5 stages, and they're very useful to be aware of. So what's we going to do for someone who's cold? So let's face it, the majority of patients, casualties we're going to see, I'm sure some of you have seen some already this year on the hillside at stage 1. I'd be surprised, but certainly, and it's worth saying that people in summertime can reach stage 1. Some of the teams may have seen some sort of stage 2 this winter gone by, and I'd be surprised, but only because it's just less common that we're able to find and treat these patients. But some of the teams may well have seen some sort of stage 3 hypothermia. So what we're going to do, we're going to identify, but realistically, we're going to treat them all relatively the same as much as we're possible. So it's all about protecting the heat that's going around their body, stopping them from losing any more, and then trying to offer them some sort of external heat. So whether that's using other body heat, huddling together, lying in a kizu with lots of people around, applying oxygen depending on how cold they are, but obviously generally the principles are the more unwell somebody is, just put them on oxygen. There's very rare a situation where putting oxygen on someone is a wrong answer, unless they're actively on fire. I suppose that would be one for the burns talk. Providing them with quick release glucose, so glucogel, or which would be our kit, what we carry in our kit. But if not, any quick release sugar, so like dextrose tablets, or even just a chocolate bar with some quick release carbohydrate, because what that does is that just pools a load of sugar into the bloodstream and gives the muscles more fuel to work with. The guidelines talk about measuring temperature either by the mouth, an oral temperature, or an ear temperature. That isn't really routinely done. The guidelines were actually written by the Lakes District group of teams who carry slightly different kit. probably due to slightly different funding streams. But certainly for our team, I don't know about Llamaris, but certainly for our team, we don't carry a thermometer for casualty use. Protect the airway if necessary. So if they're cold and their conscious level is decreased, it's a way of stopping that obstructed airway that we talked about before. So if we start to hear snoring, we might want to think about putting an airway adjunct in. Rapid evacuation. So only removing wet clothing under shelter. So once we expose skin, we don't want wind then exacerbating heat loss by blowing next to exposed skin, especially when it's wet, as you're going to get evaporation that will draw more heat off the skin. And then this sort of point, so there are a few sort of specific and quite niche points about hypothermia, and this is one of them. So when you reach the stage of severe hypothermia, so this sort of stage 4, and I guess to some degree it's probably good practice to practice it with stage 3. But essentially, the casualty has to be managed completely horizontally, and that includes in terms of evacuation if by helicopter. If you start to tilt the body head up, head down, then you get large shifts of cold and slightly acidic blood. And if you get a large shunt of that blood back up to the heart, it can then irritate the heart muscle, and it can trigger electrical problems and put them into cardiac arrest. So it's important that the casualty is managed horizontally, and big sudden movements are avoided. So that's important for sort of stretcher carrying and casualty manipulation on the hill. Probably the most important thing for your written exam when it comes to hypothermia is the distinction of is the casualty in front of me, are they severely ill because of hypothermia or severely ill because of something else? So let's just go over some scenarios. So these are 3 sort of relatively not common, but the most likely scenarios. So an avalanche, so you get immediately compacted into a really cold substance. Cold water immersion, so immersion rather than submersion, because obviously if you're submerged, then you're going to begin the process of drowning because you're having water going into your lungs. So if the body, not the airway, is underwater, get much quicker heat loss. And then finally, exposed to the elements for a prolonged period of time. So fell runners out in bad weather, drunk people who go out and they pass out on Christmas Day and fall into some snow and lie there. These are the more sort of common scenarios that we might see. So let's just say so avalanche rescue is one that gets talked about quite a lot in mountain rescue for obvious reasons. And there's a few buzzwords that they'll always mention. So one of them is that the casualty was or was not found with snow packed in their mouth and their airway. And then number 2 is that there was or was not an injury that was incompatible with life. And the reason for this is that if we take the scenario of an avalanche casualty, so when you do your avalanche training, you're putting your probing sticks down, you find a casualty, and you free them up from the snowpack. There's a few really important things that we're looking out for. So one is we're looking for an air pocket. 2 is that we're looking for snow in the airway, and 3 is we're looking for injuries that are incompatible with life. And the reason for this is that casualty, if they are unresponsive, if if they are lifeless, so they haven't got a pulse, they haven't got a respiratory rate, the mechanism of death is one of two things, or one of three things. So it's either they've slowly cooled down and they've died because their body is cold. It's because they have their airway is sort of filled with snow, and they've essentially sort of asphyxiated. Or three, that there may be some trauma from the avalanche itself that may have caused another mechanism of death. So we're talking about bleeding into the abdomen, or amputation of the limb, or a broken neck, etc., etc. And the reason why it's always important is because there's actually nothing we can do for any of those scenarios apart from if someone has died as a result of cold itself. Because if they've died of cold itself, then we're going to try and actively resuscitate them for as long as it requires, and that may be an hour plus, depending on the scenario. So if there's an air pocket and you find them, the air pocket indicates that that when they were caught in the avalanche and settled, that there was a period of time where they potentially were still able to breathe. If there's snow in the nose and the mouth, that indicates that after being hit by the avalanche, there was never really any chance where they were able to continue breathing. So they would have asphyxiated before they died of the cold. And obviously, if there's major injury, then that's an indicator that they've died from something else. And why this changes our management is, as I said, if we think that this casualty has died from hypothermia alone, then we're going to extract them, and we're going to attempt to resuscitate them for as long as required. And the phrase "you're not dead until you're warm and dead" comes here. Because we want, in an ideal setting, you would transport that cold casualty who's died because of the cold into a hospital environment, and you would resuscitate them, and you would continue to try and resuscitate them until they reached relatively near body temperature, because it's actually near impossible to successfully resuscitate someone when they're that cold, because the heart is too electrically irritable, and you just can't get it to restart. Does that make sense? I think I've waffled a lot there, but I hope you kind of appreciate the point I'm trying to draw there. Does that all make sense? Anyone have questions on that? Okay. So moving forward, so then if we think that the casualty has died from a hypothermic cardiac arrest, then as we said before, the normal rules don't apply. So we're going to continue doing CPR until the casualty gets to hospital. We're going to try and do continuous CPR on the hill if possible. That may require multiple team members to take over. If you don't have multiple team members, then we may have to practice intermittent CPR, which is suboptimal, but it's a way of doing an on and off situation. It's very ad hoc, there's no science behind it, where you do CPR for a period of time, break, transport, CPR, break, transport. And the MRAW hypothermia guidelines got a bit more information with that. We talked about managing the casualty horizontally. If we put the AED on, so they're in cardiac arrest, and we go through our BLS algorithm, and part of that is putting our defibrillator on to shock them. If the defibrillator identifies a shockable rhythm, then we only do 3 shocks and then we stop. Because the heart is so cold, it's unlikely that the electrical abnormality in the heart is going to be corrected, and so therefore we're just going to cause lots and lots of damage to the heart and the skin by shocking and shocking and shocking. So we stop, and then we'll only retry shocking them when we've managed to warm them up. And that's about it really for hypothermia. So it's a bit of a specific and niche topic, but it's one that will come up on your written exam. So yeah, any questions on hypothermia? Fine. Only because I can't see the screen. You are still with me, aren't you? Yeah.
Yeah, we're still here.
I'm not just talking to myself. Fine. Brilliant.
Yeah. Yeah, still here.
So that's hypothermia. So a really important one for you to be aware of. And then what we'll do is we'll just talk about cold injury, heat injury, and then we'll assess the diet. We'll assess the room for talking about lightning strikes. Because I don't want to fatigue you all. So hypothermia is where the whole body gets cooled and chilled down, and as a result causes significant harm to the body. If the core temperature remains okay, but you've got your peripheries that have become more exposed, then you get this sort of cold extremity injury. So it's what we refer to as frost nip or frostbite. Some of you may have experienced frost nips, some of you may have experienced frostbite. It is a more serious abnormality. And basically, this is on a spectrum of disorders it's caused by soft tissue damage due to the cold. So frost nip is reversible. It's the very, very sort of earlier stages, up to sort of about 30 minutes, where you get quite extreme exposure to cold. You can start to get some skin changes. They start to become painful. Might start to, or alternatively, you might start to have a reduced sensation. You might start to swell, and then this will progress in time to more numbed, dead skin. There might be whitening of the skin. These down here in the bottom right hand picture, this picture of these black toes, that's what people refer. People often think, well, that's what frostbite will look like, and that is what frostbite might end up looking like. But that's more of a later stage process, because the black indicates dead. Skin that's been dead for a bit of time. So that's not really kind of something we're necessarily going to see on the hillside. That's something that will be seen in the days to come. Things that will increase the risk of cold extremity injury. So when people get older, or so young people, older people who can't regulate their temperature as well. If there's people who've been drinking alcohol, so again they can't regulate their temperature as well. Smokers and diabetics who may have poor blood supply to their hands and their feet through the damage that these things cause. These people are more at risk. The treatments, again, like relatively straightforward stuff. Focus on the core warming. So don't go and put a heat pack on their hand. Work from the center outwards. So warm up their core, keep their hands covered in loose warming garments, so nothing tight. So a tight glove or a tight sock, they're just going to restrict blood flow even more. So nice loose clothing to the hands and the feet. Things like mitts, for example, are ideal for the hands. Take off jewelry before it's too late, and that pretty much applies to any injury to any limb. If someone's got an arm or a leg injury and there's jewelry on there, it's always good practice just right early on get the jewelry off, because you just never know whether there's going to be swelling later on. And if swelling occurs later on and you can't get the jewelry off, it then becomes far more difficult and troublesome. So core rewarming and nice loose warming strategy, and that's about it. And it can be painful as well, so good use of pain relief is sensible. I'm not sure there's much more to be added to that, really. Anything you want to ask about that? Fine. So takeaway messages for the exam in terms of cold injury. So simple basic principles work best. In terms of the hypothermia cardiac arrest, so assess the mechanism of injury and resuscitate if the mechanism of injury is thought to be hypothermia. So if they've died from asphyxiation by the snow in their mouth and their nose, if they've died because of trauma to elsewhere in the body, these patients are not going to be good candidates to resuscitate. but we are going to give the casualties who we think have died purely because of the cold our best chance. And it's not going to be easy to determine this, is it? So it's not black and white. You're not going to drag everyone out and make a decision and say, right, this casualty has definitely died of hypothermia, therefore we're going to try and resuscitate them. It's more that we're trying to exclude any big obvious flags that suggest that they died from another mechanism before we proceed. So we'll have a reasonably high threshold to crack on and resuscitate them, but we'll have a mindset of look, if there really isn't any point, then let's not use our resources in that way. In terms of thermal stuff, we may as well just finish off this section by talking about heat illness. So again, this is a spectrum. So it spans from heat exhaustion to heat stroke. Heat exhaustion being the initial reversible injury to the body due to being too hot. So essentially, the body is generating too much heat that it can get rid of, and that can be to a variety of factors. It might be because of the environmental conditions. It might be because we're exercising to a very high capacity that the environmental conditions mean that we can't lose the heat quickly enough. And the symptoms to begin with are quite non-specific, so headache, tiredness, dizziness, confusion, and this will progress into more sinister symptoms, sort of becoming unconscious. That really we've got this rough idea of 30 minutes where we can stop this irreversible damage from happening. So simple cooling measures are what's really important. So stop the exercise, get them out of the sun, get them out of direct sunlight, take off excess layers. Lots of oral cool drinks, so nothing too cold. There shouldn't be any sudden shocks to the body, but some nice cool drinks. Spray the body with again cool water, or pour cool water over the body to allow it to evaporate off and draw heat away from the body. If they're becoming dizzy or lightheaded, it may be because all the blood vessels have expanded and your blood pressure is dropping. So lie them on their back and put their legs in the air to redirect all that blood from their legs back towards their heart. And just be slightly more cautious about those who are higher risk. So those who are higher risk are the same as with cold injury. So older people, younger people, people who can't regulate their bodies as well, people who might be on a variety of tablets for other problems like high blood pressure, diabetes, and that's about it. So lots of simple stuff done well. We're going for about an hour and 40 now. And as much as I'd love to talk into the night time, I am conscious that it's probably getting a bit mind-numbing for you guys. So the next topic's a lightning strike, and then moving on to some injuries from insect bites, snake bites, and then a few other miscellaneous items. So why don't we see what questions are there to be asked, and then we can make a plan from there. So does anyone have anything they want to ask at all? No.
Patrick, are there past papers available?
No, unfortunately not. Only because the rules are that we're not allowed to share past papers. So we can. What we certainly can do is we can make some up that seem plausible, but I can't show you any direct past.
Because the last exam I did was in the old format, so I'm not aware of the new format in the same way.
So when you say the old format, the old format you did was only 3 years ago.
Yeah, I thought it had been updated.
No, not to any significance. It's still going to be a stem of a question and then a choice of 4 or 5 multiple choice answers. Okay, fair enough. And in terms of there was a question, there was a vicious rumor going around that the exams have got harder. The latest discussion has been is that everything's pretty much the same. I don't think you'll notice any difference.
Okay, thanks.
anything else at all? Fine. Does anybody particularly want me to carry on, or is everyone happy to I mean, I'm just conscious that once you get started on the next topic, it could be another 20 minutes or so, and I'm conscious that I'm easing up into your evening.
I mean, I think you need a break as well.
Oh no, I'll do whatever everyone wants. I'm just trying. You need to be conscious to be able to take things in, and it can be quite mind-numbing.
I'm going to dip out because we might have a job going on, so that's all right. Thanks for tonight. It's been great.
No problem at all.
Bye, see you in a bit.
Yeah, much appreciated.
Right, well, we'll draw things to a close then. If people are starting to peel off, that makes fine. First thing I'm going to stop this recording.